As you all know, the WIROC Max 2022, the 57th annual conference of Bombay Orthopaedics Society, is scheduled from 29 December 2022 to 31st December 2022 at the Geo World Convention Center, BKC, Mumbai. This year, we have changed many things. The first thing is the venue. Other things, there will be also a virtual day, which will be on Wednesday, the 28th of December 2022. On this day, we'll be offering you close to 150 surgeries on your platter, where you can go through the surgical videos of the common orthopedic problems performed by experts. Besides that, we'll be running 5 scientific halls on all the 3 days of the conference, of which there will be didactic lectures in 4 of the halls, whereas 1 hall will be dedicated purely for workshop. Besides this, we'll be also having a robotic zone, a virtual reality zone, and also many more things which you will experience once you come down to this conference. At the onset, let me ask the organizing chairman of the Bombay Orthopaedic Society and the organizing chairman of WIROC Max 2022 and the honorable president of Bombay Orthopaedic Society, Dr. Rajesh Gandhi, to say a few words. Over to you, Gandhi, sir.
Good evening, respected teachers, seniors, and dear colleagues. We welcome you to the curtain raiser of WIROC 2022. There is a quantum change in the way the orthopedic surgeons are practicing. There was a time when the orthopedic practice was primarily in a small nursing home or a public hospital. Few amongst us, like respected Dr. Sancheti sir, Dr. Vikram Shah, and Dr. Rajsekharan, to name the few, have started the institutes, namely Sancheti Hospital, Shelby Hospital, and Ganga Hospital. They have set the benchmark by starting the world-class orthopedic institutes across the country, and they have attained a global recognition. On the other hand, there was a surge in the institutional practice, where the surgeons were comfortable with facilities available at the institutes, where they could work freely without any pressure of building institutions. We have today to discuss both the aspects by a very elite panel of Dr. Respected Sir, Dr. K. H. Sancheti, Dr. Parag Sancheti, Dr. Ram Chadda, and Dr. Manish Agarwal. Thank you.
Sorry. So today, our 5th episode of Curtain Raiser, and the theme for today's episode is Era for the Future. And we are looking at how our future can be defined and which are the various factors which are going to decide the future of our field of orthopedics. Of utmost importance is the doctor-patient relationship. And to highlight on this topic of doctor-patient relationship, we have with us today a noted spine surgeon from the city of Mumbai, Dr. Gautam Zaveri, who will be speaking on how the doctor-patient relationship has evolved over a period of time. Over to you, Dr. Zaveri, sir.
Good evening. At the outset, let me thank the Bombay Orthopaedic Society and the organizers of WIROC for inviting me for this session. Today, I will be speaking about the changing doctor-patient relationship and its impact on society. One in every 4 patients who goes to a doctor or to a hospital is unhappy in some way, either with their doctor, with the hospital, or with the treatment that they have received. Why are patients unhappy? Patients are unhappy because they complain that doctors do not communicate with us. When a patient goes to a doctor, he is in pain, he is suffering, and there is a feeling of insecurity about the future. There's a huge feeling of helplessness in the patient and his family, and therefore they are contacting the doctor. Often what happens is they do not get adequate attention, they do not get relief of symptoms, there is a failure to address their grievances, and therefore they develop a feeling of injustice. Eventually this converts into a distrust to the doctor, distrust for the hospital, and towards the medical system in general. And this is what results in problems. 90% of unhappy patients do not complain, they simply go elsewhere. Every patient complaining of a problem is not a potential troublemaker. In fact, we often produce troublemakers with our behavior. If a patient wants to make trouble, he will, and in any manner whatsoever. And in India, we have seen this across the country, where doctors have been attacked, injured, and even have died. Hooligans have gone and thrashed the hospital, ransacking and breaking stuff. There has been a significant increase in medical legal cases, and healthcare workers are now preferring not to take up medical professions. On the other hand, why are doctors unhappy? And this is a short clip which I would like to share with you because it is so relevant to what the doctors are facing today.
Hello, 1, 2, 3, check, 1, 2, 3. Can you hear me? Yeah, that's great. Happy National Doctors Day. Oh, Patients Day rather than Doctors Day. Doctors are okay, but our patients are really great. Great patients. Could you elaborate? Yes. See, my mother was a doctor. Matlab, if you see her class 12 marks today with that score to get a medical seat, it'll have to be your father's medical college. But she got in and she passed out, became the best kind of doctor there is. Family doctor. The family, its previous generation and the next generation will only come to you for all their problems. Toothache to heartache. Tumi ho dentist, tumi cardiologist, tumi ho bandhu sakha, tumi ho, and they will remember your birthday. Our patients had 2 things, trust and patience. Today's patients don't have trust, so we need to have good rating. Today's patients don't have patience, and that's why doctors are getting weakened. We have to maintain rating. We become like restaurants and cab drivers. If you have good rating, you can be Munna Bhai and still have a long line of patients in front of your clinic. And that's why after medical degree, doctors need to get a diploma in diplomacy. You need to know how to present your diagnosis to your patients. Your diagnosis should be like their daily horoscope. Tell them what they want to hear and appreciate their Google research. You have already found out that you have lymphosarcoma of the intestine. Great. And you also know what the best line of treatment is. Super. Why have you come to me to ask directions to the operation theatre? Can't go straight, take right. Operate on yourself. Call me if you need anything. This one time I had a patient come to me only to tell me that he needs an ultrasound. Why do you need an ultrasound? Because whatever I'm eating, I'm ejaculating. What? Whatever you're eating, you are ejaculating. Whatever I am eating, I'm ejaculating. In a matter of seconds, मेरा पूरा MBBS syllabus flashed in front of my eyes. ये कौन से chapter में था? Body ejaculating everything it eats. Ejaculating, ejecting, vomiting. Patients who don't know the difference between vomiting and ejaculating are telling us. My mother was so strict with her patients, they would not open her mouth in front of her unless she asked them to. Karo. She was like a teacher, and I'm like an air hostess. Yes, what can I do for you? What do you think is wrong with you? What do you think I should give you? Huh? Even if you are Arjun Reddy, pamper first, treat later. Arjun Reddy hoega apne ghar pe. Why did you become a doctor? Why did I become a doctor? Because I didn't want a personal life. Sorry, cut that. Because of my curiosity and compassion. Curiosity and compassion, yes. Do you regret it? I don't regret anything. I would do this all over again. It's a blessing to be in this profession. But sometimes I think I should have become a veterinarian. Animal doctor, my cousin is a vet. She has 97,000 followers on Instagram. What does she do? Put selfies with her patients, cats, dogs, squirrels, parrots. You saw my patients in the waiting room. I have 37 followers. And I can't do this. I can't give medical advice in a fun way. Oh, you have PCOD? Then do dish on Instagram reels. I can't do that. I will ask you to get a blood report and then give you a prescription. Which reminds me, sometimes I also think I should have done a B Pharma instead of an MBBS, because ultimately the medical store guy decides what the patient is going to take. I only write the prescription. He decides, same company guy, yellow.
So, as you heard very aptly said in this clip, there has been a lowering of the status of doctors in society. There was a time when they were demigods, and now they are working simply as service providers. Patients are demanding more information, better care, but they lack the responsibility and are quick to blame doctors for everything that goes wrong. There are falling remuneration, there is an increased risk of litigation, and there is violence against doctors and hospitals. So is the doctor-patient relationship dying, or can it be revived in some way? For this, you must understand that there are 4 types of patients. There are those who are ignorant. These are patients who are unaware about their disease. They are unaware about the treatment. They have full faith in the doctor. They will come to the doctor. They will blindly follow what the doctor says without questioning. Then there is the informed group of patients who are aware of their diseases. They are aware of their rights, but they believe in the primacy of the doctor, and they feel the doctor is the best and go ahead and do whatever the doctor tells them. The modern generation of patients are the empowered and the enlightened lot who have much more awareness. They have done their research through various through the internet, and then question the doctor about everything, why, what, and when. Over the last 20 or 30 years, there has been a rapid shift in patient profile from the ignorant and the informed to the empowered and the enlightened ones. Similarly, there are three types of doctors. There is the paternalistic doctor. These were the older generation right from the beginning of time, who believed that they were the persons who were in the best position to make the decision for the patient. He or she dominates the interrogation, and the patient is expected to comply without questioning. The second group of doctors are the information providers. These doctors consider themselves to be the technical experts. They have the medical knowledge, they obtain the history, and then they provide scientific and factual data to the patient, leaving the decision making to the patient. And depending on the decision, they simply execute the patient's decision. The third type of decision makers are the deliberative doctors. These doctors work like teachers or friends. They provide a detailed explanation to the patient on every aspect of his problem and assist the patient in making a correct choice. The problem here is that while the patient is becoming empowered and enlightened, he still wants a doctor who is deliberative rather than or paternalistic rather than informative. So this is the great discord. On one side, the patients are becoming more enlightened, more empowered, but the doctors, on the other hand, have little time or interest in explaining to the patient. They still live in the times when they think the doctor is God. So patients come with expectations, aspirations, which the doctor is unable to fulfill, and this leaves the patient angry, upset, unhappy, abusive, and violent. The first thing a doctor must realize is that when the patient comes to you in your clinic, it is unlikely that whatever you tell them will not cure them. Treatment and cure of an illness comes over a period of time. In order for you to get that time, you need to get the trust of the patient. And therefore, the first job of a doctor is patient satisfaction. Here are some lessons that have been learned from the Bhagavad Gita. When Arjuna went to war at the Kurukshetra Maidan, and he saw his uncles, his teachers, his cousins in the opposing camp, he got frightened and he refused to fight the war. At that time, Krishna went through 18 counseling sessions which form the Bhagavad Gita to explain to Arjuna why he needed to fight the war. In the first session, Krishna only listened to Arjuna without any interruptions whatsoever as to why he was reluctant to fight the war. In sessions 2 to 17, Krishna then spent a lot of time explaining to Arjuna what was the reason for the war, why he needed to fight the war, and reassured him that he was doing the right thing. In the 18th session, Krishna noticed that Arjuna was still confused and still not ready to go ahead. And at that time, Krishna revised the entire situation with him, explaining to him and reassuring him that this was the right step. And therefore, empathetic and effective communication is the key to a good doctor-patient relationship. Do you know how quickly does a doctor interrupt a patient's opening statement? The answer is 23 seconds. And how much does an average patient need? Between 90 to 150 seconds. In a survey of patients who were consulted, only 23% of the patients were allowed to complete their opening statement by the doctor. An effective doctor-patient communication follows the principles of the pseudonym ALERT. ALERT, A means acknowledge. When the patient comes into your clinic and is seeing you for the first time, please greet the patient with a hello and introduce yourself as to who you are, what are you doing, and what is your experience in treating the patient, and get to know a little bit about the patient himself. The second principle is L, that is listen. During this phase, you listen to the patient patiently without interrupting him, and you must be seen to be interested in the patient's story, acknowledge the patient's complaints at that time and from time to time so that the patient feels that you have heard them out. The third step is then to explain to the patient the pathology, the treatment, the outcomes, etc. In the fourth step, you must review the entire thing because the patient often has not understood what you have told them. They are not medicos, you need to be patient with them. And in the last stage, when they are leaving, it is your job to thank the patient for being with you and maybe even get up from your chair and accompany the patient to the door so that they feel that they have received the best information. So the doctor-patient relationship is changing. In the last 2000 years, doctors were treated by the patients as demigods. Whatever they said had to be followed without questioning. Today, this relationship has changed. The patients are more enlightened, more empowered, and the doctor has become more like a service provider. And if you are a service provider providing some service to a consumer, you must do it to the satisfaction of the consumer. And this is something which a patient must realize. I'm sorry, the doctor must realize. We can always say that patients also need to realize this. But it is far more difficult to educate 1 billion people than to educate a few thousand doctors. So friends, it is for us to have a successful doctor-patient relationship. It is vital that we follow the principles of ALERT, that is acknowledge, listen, explain, review, and thank. Thank you very much.
Thank you, Dr. Gautam Zaveri, for that outstanding talk on the evolving doctor-patient relationship. He has given that mantra of ALERT: acknowledge, listen, explain, review, and thank while consulting the patient. The doctor-patient relationship is something that's indeed going to frame our future. Another thing that is going to evolve and frame the future of our field is technology. And in technology, it is suspected that artificial intelligence and robotics will be the one which may shape our future. When it comes to artificial intelligence, the application in orthopedics include image recognition, risk prediction, cost outcome determination, and clinical decision making. Artificial intelligence in orthopedics is transforming how surgeons do their job by improving their clinical decisions. We are also seeing the application of robotics currently in the field of knee replacement, hip replacement surgeries, spine surgeries, and they are bound to spread into other subspecialty also. To enlighten us about the future of artificial intelligence and robotics in orthopedics, we have with us today Dr. Vaibhav Bagaria, who is the Director of Orthopedics at HN Reliance Hospital at Mumbai. Over to Dr. Vaibhav.
So good evening, everyone, and thank you, the WIROC team, for inviting me to this interesting session on curtain raiser. I'll start by sharing my screen today. So my brief is to talk about the future of robotics and AI in orthopedics. Many of you know me. I'm Vaibhav Bagaria. I work at the Sir H.N. Reliance Foundation Hospital in Mumbai. And I look forward to meeting you all at the WIROC, which is going to be a melting pot like always. And of course, we'll be talking about the future more and more. So what does future exactly hold? And I think future is like a crossword puzzle. And when we talk about orthopedics and orthoplasty, it's what are the key pieces? And I think there are 4 key pieces in this crossword puzzle. We need to be good in our technique. We need to use appropriate technology. We need to create a good team. And finally, we should have a talent for whatever we do. And in today's curtain raiser, I'm of course talking about what technology is and how technology is going to transform all what we do. But in the end, it is technique, and technology is part of technique. There's no strength that will stop us if we use the right technique and technology to deliver where we want to go. We also know that the shift is happening, and we have seen it all around us, whether it is driverless cars, flying taxis, teaching, and of course, robotics when we talk about arthroplasty. And no aspect of our lives is left untouched with the current development that is happening all around us. And and we live in a very exciting decade, and I tell this to everyone, this is the decade of change. The Renaissance happened a couple of centuries ago. This is the tech Renaissance, and I think if we miss the bus, we miss the bus. When we talk about orthopedics, and I am a joint replacement surgeon, so I talk more about arthroplasties, we know that there is a need for improvement in what we do. When I talk about total knee replacement, there are a very large group of patients who are happy. They are very, very happy. It's one of the most successful operation ever devised, but yet there is scope for improvement. And of course, we have failures that we want to avoid. And most of the knee revisions we know are because of instability or malalignment. Now, when we look at the robots in industry and medicine, both have common root, but they do not share the same rationale. The industrial one, the aim is to replace the human being with automation. But that's not so when we talk about robot in arthroplasty. The surgical robots are an advanced tool that aid surgeon and not substitute them in the surgical room. And our own role, our own knowledge, our own experience are complementary to whatever the robotics bring to the table. And that's the key difference. And I think we all must understand that technology is what we make of them, what we desire from that technology. In arthroplasty, where my own specialty, I've seen that it has evolved from conventional instruments. We had early balancing tool. We came into navigation, which came in with a hype, but was considered a wine before its time. We came to early robotics, and today what I use personally and what most people use are handheld robotics that help as a surgical guide, improve execution accuracy. They allow you to do gap balancing in kinematics in a relatively image-free environment. Of course, there are different types of robotic system, which are image-based or image-less, active, passive, semi-active. But regardless of the typology of the robotic system, the aim is to improve precision and accuracy in arthroplasties. We still are in charge of planning and improving the operation, only that the precise execution and giving objective data of what needs to be done is what has made the change. Of course, the robotic war is going on, and today you'll see Veles, Stryker, Mako, Navio, Cori, Rosa, QS. They're all around us, and you'll see more and more and hear more and more about these. We will keep getting different versions, different software upgrades, and more intuitiveness in these system. And picture abhi baki hai, party to abhi shuru hi hai in that sense. When I talk about arthroplasty, I'll take that as a simple example because that's my field. Our mechanical goal used to be restore alignment, preserve or restore the joint line, balance the knee, use precision in component alignment, and get a great patellofemoral tracking. But we also wanted all that to happen in minimal surgical time with least infection rate, reduced pain, reduced stay. We wanted people to be happy. I wanted to be happy at the end of the operation, and my team to be happy. And of course, cost effectiveness was a goal. And of course, when that happened, the surgeons moved into this era of robotic surgery with pre-op planning, intraoperative executions. This is the robot that I use. Key steps in any robotics is setting it up, registration, planning, bone cuts, validation, trial implantation, revalidation, final component, and then closure. Now, they remain constant irrespective of robot use. And I stress this point because there is a lot of hype around this robot is better or that robot is better. But to me, all robots depend on what you want to execute. They should be a means to an end and not end in itself. And I think that's what the future is. If you know what to, it's like driving a car. You know what's the most important part of driving a car? It is to know where you want to go. You can have the best car. If you did not know where to go, you will end up in a wrong direction. All of these are what are cars made of. You need good cars for sure, but you need to know where you need to go. So the era was of, and I use this analogy, is that the navigation was the era when we had GPS-like structures, which told you how to reach a particular place. Then we have chauffeurs, which are like PSIs. You can Uber or Ola, you can call for them like a PSI block, fit them in and tell them this is where I want to go. Tesla came in with a driverless car. That's what robotics is. But eventually no one can and no one should change the fact that you are the one deciding where to go. Again, standard steps for all robotic things. We know that there are key alignment philosophies, and that's how, as human, we change. We change from different alignment and balancing philosophies over the years. And this is the era which I call is the era of intelligent alignment, where our intelligence and our expertise will be combined with artificial intelligence. And we'll work hand in hand with robots to change the way we look at things. And we know that we want to be accurate and precise, and being not accurate, not precise is not the way forward. But we have become cognizant of the fact that our patients are all not the same and that our targets are moving. And that's, again, one area where the robots help us decipher what is right for our patients. For example, when we do a knee replacement, we understand there are alignment of freedom that we need to, or that can be potentially exploited. But understanding that there can be literally thousands of permutation combination. And if you had a structure which told you objectively, this is where you go, it will be a game changer. With experience and skills and planning, we can reach there. But with the technology, I think this is where we hit. We still have outliers, but we'll be much closer to the target that we want to reach. And I think robotic is making that possible, especially in knee arthroplasties. A word about AI. A lot of things are taught about the world of artificial intelligence, and I think AI and robotics both go hand in hand. And I think predicting the future isn't magic, and it's artificial intelligence. If we had enough data to prove or to say that this is what it is, we'll be able to predict future. And at our center, we start with small things. We've gone into this AI, and that's the reason why I've been called to deliver this talk, is that we use AI at our centers in all of these that you see in record management, drug development, medical imaging processing, remote patient monitoring. But personally, what we do is the project that we work on called as deep learning algorithms for osteoarthritis, and this is the algorithm that we created. And all of this have shown that actually the AI algorithms are better than humans. So you'll see this is our first study on osteoarthritis. You'll see our results are very good in terms of being able to predict the grade of arthritis. Similarly, we published it, and we found that one of our models that we evaluated, DenseNet, was actually better than humans. And that's held true with consistently over time in other things also, where we use this, and this is an example. We are using one of those things to tell whether which grade of osteoarthritis, and you'll see that computer accurately predict that it's a grade 0 arthritis, so there's no arthritis at all. We did a similar thing with our knee implant detection, and once again the AI algorithm proved that they were superior than us. A bit heartbreaking, but that's the true. We published it once again in Journal of Orthopaedics, proving that, yes, that's the fact that the AIs have become smarter than us. Again, one of the demos. We are working on the hip implant detection data again. We shall be able to do, and we'll not be surprised once again that the AI beat us. So in short, my dear friends, it's all there. The AI will help develop a solution for accurate analysis of skeletal radiographs. Will help train the doctors about the possibility of better treatment modalities. It will also contribute in terms of a real-time checks on our patient. Coming back to robotic, it will help us do better robotic surgeries by giving us better data, better suggestions while we are operating. And thus, overall, it will improve our surgical outcome. But in the end, and the heart of operation is the surgeon and the patient. And as long as the technology help us, I think we'll be good. I'm often asked this question, that is there a race, is there a debate that who is better? Whether the robots will eventually will replace them. And I'll only end up with this video here, where you'll see the robot is outpacing humans in every aspect. But you'll see that they outpace us in cycling, everything in execution, they will outpace us. But it is only worth it. It's only worth it if we enjoy it. So I think picture abhi baki hai. We need to work together. Technique, technology, and teamwork, all elements are critical to success and optimal patient outcome. Newer technologies help achieve our desired outcome more efficiently and accurately. Knee replacement that I do with robotics has definitely brought about a paradigm shift in way we perform or I perform my surgeries. It performed an average me to think better and a better me to become best. At the end of whatever we do, whether it is robotics or AI, it is a quest for excellence. And technique and common sense and having a good team are essential no matter what the technology gives you. With all things, the picture abhi baki hai, party abhi shuru hui hai. We'll keep listening. We'll keep knowing about good things to come. But last but not least, I would want every one of you to think about this. The best way to predict future is to create it. And it's the right time to be part of this revolution. We all need to work towards getting the AI as a part of our own ecosystem, use intelligence, and help develop it for an optimal outcome. Once again, thank you, everyone. Thank you, Abhijit and Ashish, and look forward to seeing all of you at next WIROC. Thank you.
So thank you, Dr. Vaibhav Bagaria, for that wonderful talk on the robotics and artificial intelligence in orthopedics. How is it going to shape our future? It's said that one thing that's constant in the nature is change. Change is inevitable. The earlier we get adapted to the changing scenario, the better it is for our future. As Charles Darwin had rightly said, that it's ultimately the survival of the fittest. And the more you change, the more you adapt, the more fitter you get as per the time and the surroundings. Our next talk and next speaker is going to be about the keyhole surgery in spine surgery, which is again reshaping the entire field of spine. And to speak on this, we have with us today Dr. Arvind Kulkarni, a noted spine surgeon from the city of Mumbai, and he will enlighten us on the future of minimally invasive surgery in the field of spine. Over to you, Dr. Arvind.
Dear friends and colleagues, it's a matter of great prestige to be invited to speak on this pre-WIROC platform on the topic of future of minimally invasive spine surgery. I thank the WIROC as well as BOS team for remembering me to speak on this particular topic. I'll start with this small video. Spine surgery is on its way out of the windows and the door. Because minimal access spine surgery is well established now. We all know that it is percolated everywhere, and it's wanted. It's demanded by surgeons in terms of learning and demanded by patients in terms of service. So it's so well established that it's almost 4 years since we published this particular 400 pages textbook. This is the official publication of Minimally Invasive Spine Society of India, which is now called MISAB, that is Minimally Invasive Spine Surgeons Association of Bharat. And we have internationally a big society which we are affiliated with, that is the Society for Minimally Invasive Spine Surgery. Similarly, many countries have their own societies, and we collaborate quite periodically. So much so that the official journal of Minimally Invasive Spine Surgeons Association of Bharat, that is our society, has Journal of Minimally Invasive Spine Surgery and Technique, which is published by Korean as its official journal. You will also find our name here as one of the associate editors. So we are quite, in tune with what's happening all across the world. So, and we are at the forefront. Indians are at the forefront of minimally invasive spine surgery. I will illustrate this situation with some case examples. So this is an extremely obese patient. He is 140 kgs. He's a middle-aged male. He has a high BMI of close to 50. He has severe radiculopathy lasting close to 6 months. And this is secondary to a left-sided L4, L5 disc herniation. MIS surgery is a boon in such patients. Using a small tube, which is about 14 millimeter in diameter, we could perform a discectomy and send him home the next day. This is him walking, the evening of surgery, just outside the operation theater, outside the recovery of the operation theater. So that is the kind of dramatic recovery and relief. But once one gets following a minimal access, there is hardly any collateral damage to the tissue, and that is seen in the patient's recovery. So this is the magic tube through which we accomplish our goals of either decompression, discectomy, fusion, which are the basic elements of spine surgery. This is another landmark paper that we published, as one as a technique and one as a review paper. This is the first case in the world where spondyloptosis was done using minimal access spine surgery. So you can see this particular surgery is difficult even if you do it in an open fashion. So MIS has its own intrinsic positives and virtues, because of which such surgeries can be performed with minimal trauma to the patient. You can see a significant improvement in the lumbosacral kyphosis and an excellent reduction of the spondyloptosis. This is in a 44-year-old lady who was desperate to get this surgery done only through the tube. Another very interesting patient where this patient had a left-sided S1 pedicular osteoid osteoma. It would have been a hunting game if you had done it as an open procedure using a right combination of navigation and minimal access using these tubular retractors with a tube which is about 18 millimeter in diameter, aiming right at the pathology with the help of navigation guidance and navigation compatible burr, a neuro drill. We could localize and excavate and do a pinpoint surgery without causing any collateral damage. So you could see that post-operatively on the table we could do a CT and check the accomplishment of excision of the osteoid osteoma. So this is the advantage of minimal access surgery. Another case in point is this elderly lady with a high BMI, with chronic diabetes, with chronic complaints secondary to 3-level stenosis, L3-4, L4-5, L5-S1, who needed a 3-level TILIF, which was done percutaneously using these tubular retractors and percutaneous pedicle screw rod system. So you can see the scars. It is unimaginable. You can imagine the kind of incision and torturous trauma the patient would have had to undergo if it were to be an open surgery. So all this was done, unbelievingly using these small cuts here. So that is the benefit of MIS. Apart from these case examples, these are just some of the cases that I've shown you, and this is something which we do. These are the kind of cases which we do routinely. So we also established futuristic concepts. One is, while the West taught us how to do this over-the-top decompression using tubular retractors for mild and moderate stenosis, we have not only shown the steps as well as showed the feasibility and even displayed the outcomes of tubular decompression using over-the-top technique for severe stenosis. So these were published in well-established journals. Again, we are the first to show that more than one level decompression can be done using tubular retractors. Close to 3-level decompression could be done using one single incision of about 1.5 to 2 centimeters by just redirecting the direction and trajectory of the tubular retractors in selected cases. Again, we were the first to demonstrate to the world that in spite of continuation of antiplatelet therapy in certain situations, one could still go ahead and accomplish a minimal access decompression. There is hardly any difference in the morbidity. This is of great value in patients who have severe symptoms and who have been advised to not stop antiplatelet therapy either post CABG or any other procedure. Again, in terms of decreasing accomplishing the goals of decompression discectomy by using smaller diameter tubular retractors, we have demonstrated that we could do it using a 14 millimeter tube, and recently we have started using a 12 millimeter tube, while worldwide it is usually 16 and 18 millimeter tube that is used. So we have established quite a bit of these kind of futuristic concepts which are appreciated all across the world, and we also could establish the performance of tubular discectomy under local epidural anesthesia. You can see here I am talking to the patient and performing this particular discectomy procedure, and she is just on oxygen and she is talking to me. She is chatting with me. So this patient goes home the same day evening because she's not exposed to any kind of anesthesia, sedation, etc. She walks in the recovery and goes home in the evening. We also established that, so infection is something that is very crippling to the patient as well as to the society in terms of morbidity, in terms of economics, in terms of the psych. So we have shown that minimal access spine surgery minimizes surgical site infection because the exposure of the tissue to the exterior is very less compared to an open surgery. So what's next? What lies in the future? So this would be discussed in the next few slides in terms of all the stakeholders which are integrated, that is the procedure, the surgeon, the patient, and most importantly, the training of future MI spine surgeons. So this needs to be redefined in terms of motivating, innovating, and integrating all the four stakeholders, which goes with the theme of this particular year's WIROC. So in terms of procedure, where are we now? So spine surgery basically consists of decompression and instrumentation. So while decompression is achieved using tubular and endoscopes, the instrumentation is usually performed using image guidance. And the most common image guidance that we use is the Shyam, navigation, and robotics. So this is the current, state-of-art technique that is used. What lies in the anvil is 3D endoscopy in terms of minimal access decompression, wherein you can perceive the depth much better in terms of a 3D immersive field compared to the 2D field that we use now. Again, in terms of instrumentation, there is a lot which is lying ahead of us. So right now, the most common technique of using of performing percutaneous implant fixation, that is pedicle screw fixation, rod fixation, is using Shyam. And then some centers have navigation and some centers have robotics. So what lies in the future is augmented reality. So by definition, it's basically superimposition of a computer generated image on the user, that is the surgeon's view of the patient. So the patient is lying flat on the operating table and you have preloaded CT of the patient, which you are going through through the augmented lens, which is on your forehead, and that is where you're going to get the virtual image of the patient. You're going to get the virtual image of the spinal virtual image in front of your eyes in all three dimensions, that is sagittal, coronal, and axial, and that helps in putting your implants in. So this allows most procedures to be done percutaneously. This is similar to stealth and navigation in terms of its origin. It comes from military. In this particular technique, you don't have to repeatedly keep nodding your head up and down to see the image on the screen like we do it with either the Shyam, navigation, or the robotic. It's a real-time picture. It is accurate. It is basically a 3D image overlay of the patient, which you can see on your screen when you're operating on a patient without exposing the patient's back. It is easy, it is simple, and it is precise. So it is third generation instrument when you think of the Google Glass. So I'll show you a short video. Here you can see that the patient is lying on the table. The patient's posterior elements of the spine are not exposed. They are seen on the bony element. The spine as a bony structure is seen on the screen of the augmented reality lens by the surgeon. Additionally, the surgeon gets to see the axial as well as the sagittal image so that he can put the implant in. So this is percutaneous fixation. These are the images of the patient's bony skeleton that are seen on the augmented lens. So how magical it is to get the right depth of the screw, right diameter of the screw, and right trajectory of the screw. So this is being done already in certain centers. So that is going to have a big impact in terms of surgeries being performed. You will not need a navigation. A combination of this and a robot which can help you in spinal osteotomies, etc., will make things so simple that you can use a robot to operate on the patient while you are controlling everything from home. The other applications of the future would be artificial intelligence algorithms in spine, which will streamline referrals, which will be able to show which patient should go in for a minimal access to a minimal access surgeon, which patient would go to an open spine surgeon. They'll help in predicting outcomes and complications following a particular procedure, which would be relatively low with MI surgery, which would help in defining whether a patient would benefit or not benefit from a particular surgery, and also help in designing patient-specific implants. What is the future for the MIS surgeon? What lies in the future for the MIS surgeon now? So he has to be techno-savvy. He should have enough patience to learn, otherwise he'll lose out in the competitive world where the patients are pushing for MIS surgery, and the high level of competition among surgeons to learn and deliver goods. There is going to be a lot of stress on the surgeon to learn these techniques, and definitely needs to learn a lot of patience. So earlier the adage would be, bigger the incision, bigger the surgeon. Till a few years back, when it changed over to shorter the incision, bigger the surgeon, the next statement would be the more well equipped and more augmented the technique, the bigger would be the surgeon. So there will be a lot of demand on the surgeon to be well augmented, to be well equipped with technology. What we'll see in the future is that there'll be no more celebrity or star surgeons, because almost everyone will be at par, because technology will rule us. So we'll be reduced to a technician. Anyways, we are always labeled as carpenters. So while the surgeon might lose out his star status, the patient will be the king. So he'll be the winner, and he'll be a quiz master as well, because he's going to ask you a lot of questions, and technologically it's very important for the surgeon to be well versed with these techniques in terms of answering questions too. And definitely because of the precision, because of the safety, because of the innovative thought that is put in performing a particular procedure, as well as case selection, there's going to be an early return to work and activity. There's going to be a definitive reduction in morbidity, complications, and because most of these techniques in the future will be very precise and could be done in the shortest time, and probably under regional anesthesia, there will be a good provision of including otherwise unfit patients who would not stand long hours of surgery under general anesthesia. And this is going to be an elaborate topic, that is training. How will we train our forthcoming generation in terms of MIS? That also, in terms of technology augmented MIS, this is going to be a definite challenge. So I would still emphasize the fact that they should be good open spinal surgeons first. Let me give you an example. So this is a gentleman who is quite elderly. He's bedridden for about 3.5 years because of his stenosis at D11, D12. He's paraparetic, and for the last 6 months, he's become incontinent. And this patient was referred to me for a decompression, for a tubular decompression, because I do MIS procedures. So this stenosis was exactly at the apex of the dorsolumbar spine, and he was sent, as I said, for decompression. So if you see here, the problem here is not of compression alone. The problem is mainly of the deformity. So this is the apex, and at the apex of this dorsolumbar, the spine, the cord is getting compressed. If you do a decompression here by doing a laminectomy or a minimal access decompression, you're going to just make him worse, because you're going to exaggerate or exacerbate his kyphosis, and he'll reach a point of no return. So what this patient needs is basically an osteotomy. So you're going to indirectly decompress this particular patient's spinal cord by performing an osteotomy and correct the deformity. That is how, by pushing the spine to the front, you're going to decompress the spinal cord anteriorly. So this is what was done. So an osteotomy was done. You can see the wedge-shaped osteotomy that was performed in this particular patient by excising the pedicle from both sides, excising the end plates of the inward levels from both sides, and then using the cages as a fulcrum to correct this particular person's deformity. So this patient went home walking in a few days. Had I done a decompression, this patient would have never got up from his bed. So this is a kind of basic spine principles that the spine fellow or the trainee should learn first. Another example would be, just because you learned how to put percutaneous pedicle screws by attending some workshop, you don't do unnecessary surgeries. So just because you have a tool in your hand, you just don't use it. A tool, tool without knowledge, is a person with a tool without knowledge is a fool. So this is a elderly lady who has stable fractures, and just because you learned pedicle screw fixation, we don't put pedicle screws and rod like this. So this is the kind of training one should know. Not only should the trainee be trained in open surgery first, which is intrinsic to learning minimal access spine surgery in the future. It is not just the feel of the tissue, it is also learning about case selection, when to operate, when not to operate, whom to operate, when to operate. That is much more important than learning a particular technique. One of my senior professors would tell, even a monkey can operate. So after a particular time, after a certain experience, it's very easy to adapt to navigation, robots, augmented reality, labs, etc. But what is most important in the training phase is case selection. And this is very, very intrinsic to any kind of advanced learning in the future. So the message is very clear. Minimal access spine surgery in the future is going to be exciting, very exciting. We'll be learning much more beyond biology, things that are not taught in med school. So it's very important for us as spine surgeons and the futuristic spine surgeons to brace up for rapid advancements and adapt, because we need to remember here what Charles Darwin said, it is survival of the fittest. Thank you.
So that was an outstanding review of the role of minimally invasive spine surgery by Dr. Arvind Kulkarni. And our last speaker of the day is Dr. Ashok Shyam. Dr. Ashok Shyam is going to speak on orthopedic research in India, a road less travel. If we look at medical research, it can
Good evening,
broadly be
everybody.
classified into.
I'd like to thank Bombay Orthopedic Society, Dr. Abhijit Kale, Dr. Ashish Phadnis, and Dr. Rajesh Gandhi for this opportunity of speaking to you on this curtain raiser of WIROC Max. So my topic for today is orthopedic research in India, a road less traveled. The session topic today is the view of future. However, for me, future is a continuous road which goes from past to future. So we need to understand our current paradigm correctly so that we can talk about what future holds for us within our own reality, not an extrapolated one, not something which is not practical or not frugal. So let's understand what is the orthopedic research paradigm. Let's begin with defining what research is, which is one of the most important missing key point in the research scenario today. What is research? For me, it is pursuit of knowledge for betterment of patients. That is the whole complete foundation definition of what research is. It has been misunderstood by many and it has taken various shapes in current scenario. But this is what the basic definition is. We are conceptual people. We interact with the world and make our own paradigms. That's what I'm saying. When we hear of word research, different ideas come to our mind. These are a dynamic paradigm. So as the new information comes in, these paradigms keep on changing. For example, today I'm going to share some new ideas with you, and maybe it adds to the information that you already have and shifts your paradigm a little bit. So it is a dynamic paradigm that we work with in research. This entire thing is what I feel is research. Research is a way of life, how we interpret data points, how we interpret technology and utilize it. The entire process is research for me. As surgeons, we look at past, present, and future in terms of research studies, retrospective, prospective, cross-sectionals. We share our experiences and publish them in journals. But the entire process, like I begin with, I might be sounding repetitive few times, but these are the core ideas that I'm going to forward. So why do we do research? Pursuit of knowledge for betterment of patient. That's the whole foundation of it. Orthopedic in research in India is since antiquity. There are certain differences where orthopedic research in India or research in India comes into play. So medicine in India was always teacher-centric and patient-centric. So these are two focus, and still these are the two main focus of medicine in India. While in the Western world, it was mostly literature-centric and a lot of it was population-centric. So these are the two basic philosophies that India differs from in the Western world and in other countries. So this philosophical differences created a barrier in developing a culture for research and publication. We are very good at interacting with our patients and learning from our teachers directly. But producing literature out of it and population-based literature out of it was never a part of our culture. That created a lot of hurdles for us in terms of publishing. However, this, like I said, the paradigm was dynamic. We grasped new information from the Western world. We started introspecting ourselves, and this led to certain change in late 1900s and early 2000s. This is a very good example that I'd like to give. This is a Padar hospital somewhere between Madhya Pradesh and UP. It's a tribal area. That's the hospital, small locality, where Dr. Nihar Padi was working between 2002 and 2006. He collected data of all the tribals who have fallen from height, like fall from tree or a small hill or something like that. And all the compound injuries he treated with laser of fame. He kept a record of all of them, and he published a very frugal paper on this thing, which was cited and highly read, and it made a lot of difference to a lot of people. So this is what I call is a very impactful publication. So like I said, there was a lot of introspection in the first decade and the last decade of last century and first decade of this century. Lot of quality papers came from India. Their papers were few, but very good quality. Then something changed. There was a policy update. It was implied in 2017. It was, I think, made available or first formulated in 2012 or 13, but it was enforced in 2017. The policy was that publication and research will be key to promotion. And this changed the entire paradigm again. And I'll show you how it changed. This came overnight. The enforcement was like very sudden for all the academia in the country. There was lack of guidance. There was no infrastructure provided for doing research. There was hardly any research education in our postgraduate curriculum, even to our teachers. There was absolutely no funding and no information about avenues to how to get funds about. There was huge research apathy. And like Johnny Marvin said, it is difficult to be motivated if there is widespread apathy. This apathy was widespread among the entire academia of not only orthopedic but medicine in India. And there was huge research lethargy amongst students as well as teachers. But since it was enforced by the government, it led to something which was very troublesome. It led to academic misconduct. There was huge amount of academic misconduct that happened. Data falsification, manipulation, plagiarism, ghostwriting. Being editor of few journals, I am privy to all of this. And this made headlines across the world. So fake research paper shops. A lot of data from India was questioned all across. Not only that, predatory journals flourished like anything in India. There was an entire group of predatory journals that came out of India during last decade, and this tarnished our image all across the world. We produced a lot of literature. Number of papers that were published in last decade was huge, but they're all almost equal to rubbish. Again, there was a need for introspection. After all this has happened, we need to understand why do we need to research. It's pursuit of knowledge for betterment of patient, not just publication, not just putting in content. So this is what we need to understand when we move to the future. What does future hold to us in research and development? It will be a technology-driven process. Not only research, but even the education. Both go hand in hand, and technology will play a very important role. Education, I think last 2 years, COVID has transformed education, and a lot of digital elements have come into play into education, even orthopedic education. This was a survey done in early this year by Zaveri and others, which says that remote learning or remote education will be around 37% in next 10 years. So that is where we are looking at digital education and online education. I'm glad to say that India took a huge leap, especially in orthopedics. We had the OrthoTV channel, which was viewed more than 50 lakh times, and it is a major source of free online education in Asia Pacific, Middle East, and Africa. As a part of the team, I get a lot of queries and people looking at the channel, learning from it. So that is where India took a leap, and we are glad for that. Like Vaibhav said, virtual reality, simulation, All this will play a major role in education. Even artificial intelligence will take a major role in education and training of orthopedic graduates. AI will take special role in research, especially in identifying data points, in collection of data, in core research organizations. AI will be integrated in terms of searching for valid and relevant questions. Even I predict even in publication area, AI will play a very important role. There'll be AI peer reviewers. They'll do the relevance analysis of the paper, whether it should be published or not. So in the end, along with the peer review, along with the editorial staff, there will be AI that will be deciding on publication, whether it can be published or not. Big data will be huge in the future. Big data and big collaborations. So these are both big words for research in coming future. How will India play a role? India has big data, has big technology, but there is the danger of India becoming a data harvest center for the Western world. If we don't utilize our own capacity, if we don't do our own capacity building in all of these areas, we will just become a data harvest center for big research happenings. We have to realize that it is our time. Apna time aa gaya hai. We have to build our own capacity, take hold of our own data. There is increased number of publications from India in top journals, which is a very good thing. But like I said, we need to understand we have big data, we have big technology. We need to do a big cultural change. We need to understand why do we do research and do frugal research that is applicable to us. We need a lot of introspection. We need to understand that it is a moral, social, scientific responsibility to publish, and it is also a measure of our integrity. It is a road less traveled. It's not an easy road. But then, if not us, then who? Thank you very much.
Thank you, Dr. Ashok, for that wonderful talk. If we analyze medical research, it can broadly be classified into clinical and academic research. Clinical research is the one which is promoted by pharmaceutical companies, whereas academic research is the one where the initiative is taken either by surgeons or clinicians who try to come to some conclusion for the betterment of the future. Textbooks and reviews are synthesis of these academic research studies that are published in peer-reviewed journals. Establishing a network of surgical research across India is necessary first steps towards taking global leadership in orthopedic research. And I guess Dr. Ashok Shyam and his team has taken right efforts in taking our national leadership in orthopedic research that indeed holds a big future. On the behalf of the organizing committee of WIROC Max 2022, I thank today's speaker, Dr. Gautam Zaveri, who spoke about the future of doctor-patient relationship, Dr. Vaibhav Bagaria, who enlightened us about the future of artificial intelligence and robotics in orthopedic surgery, Dr. Arvind Kulkarni, who spoke about the future of MIS in spine surgery, and lastly, Dr. Ashok Shyam, who spoke about orthopedic research in India, a road less traveled. Thanks everyone for joining us today. Before we conclude, let me highlight you about what's up in WIROC Max. We are barely 5 days away from a conference that's very dear to our heart. That's WIROC Max 2022. So myself and my team members my co-organizing secretary, Dr. Ashish Phadnis, and our guide, Dr. Rajesh Gandhi, who is the organizing chairman and the honorable president of the Bombay Orthopaedic Society. This year, the venue for our conference is Geo World Convention Center, which is located at the G block of the Bandra Kurla complex in Mumbai. As we all are aware, BKC is turning out to be the new nucleus of our city, and this would be accessible to everyone who is in the city of Mumbai, as well as all the delegates who will be coming across Maharashtra, India, and also across the world. So this new venue at the Geo Convention Center also gives us a lot of hope. It has given us a new breathing space. If we look at our scientific halls, they are spread over wide areas. We have got over 1 lakh square feet area at the Geo Convention Center, where we will be having close to 4 scientific halls, where didactic lectures will be held across 3 days, along with the 5th hall, where there will be workshop for all the 3 days. We offer you a break from the routine and a taste of good times. We are looking forward to providing you with an academic feast, also provide you with a platform for a great time to network, reminiscence, and catch up with the friends at the WIROC Katta, which will be a new initiative. The highlights for this year's conference are, we have a 3D printing workshop, where we can see how 3D models are prepared in planning complex surgeries. Also, 3D printing is changing the world of orthopedics, the applications, and there will be a hands-on exercise on this. It's bound to revolutionize the orthopedic treatment module and is bound to add value to the subject. Also, this year we have created robotic zones. And as we have just listened from Dr. Vaibhav Bagaria, what robots holds us for our future. We have a robo coming from the house of Merrill, as well as from Smith and Nephew, where you can have a hands-on experience on the robots. We have also created a virtual reality experience zone where all the delegates can experience it. This has been sponsored by Depu Synthes. The issue is, can virtual reality training churn out better orthopedic surgeons in the future? We will have skill zones for the delegates who can check how the advances are taking place. Also, the adoption of virtual reality in orthopedic training and what it holds for the future of orthopedics. During this conference, we'll go beyond the conventional and go through all that's latest in the field of orthopedics. It would be taking a step forward in orthopedics. Also, we will be having an orthopedic surgical video theater where we'll be showcasing close to 150 surgical videos. Also, we have trauma-plasty battles and debates during the conference. This year, the highlight of the conference is we have created a separate zone, a separate section, which is known as Kaleidoscope, where we will highlight anything but orthopedics. Here, one can exhibit their skills in painting, photography, sculpture, fine arts, literature, music, sports, and many more hobbies, and demonstrate how one can stay fitter and physically longer. This will be wholly sponsored by our members and delegates. This year, the guest speaker for the presidential guest lecture is our ex-Olympian director of the Olympic Gold Quest, Mr. Viren Raskina. And this year, regarding the plenary sessions, the prestigious R.J. Katrak oration will be delivered by Dr. Sanjay Agarwala, whereas the late Dr. K.T. Dholakia eponymous lecture will be delivered by a noted radiologist, Dr. Ravi Ramakant. Also, the late Dr. A.K. Talwalkar symposium will be on pediatric supracondylar humerus fractures, and Dr. Rujuta Mehta and Dr. Binoti Sheth will be leading this symposium. And another speaker in the presidential guest lecture will be Dr. Yadvendra Jhala, who is a senior professor and the dean of the Wildlife Institute of India at Dehradun. As we all know, recently cheetahs have come to India and they have traveled across the African continent to our country. And Dr. Jhala was the one who had led this movement. So the journey of how cheetah and the conservation of wildlife in India will be narrated by him. We have the backing of the entire executive committee, and we look forward to welcome you for a conference with a difference where there will be a perfect blend of academic fest, innovation, and networking. I request you with the folded hands to come and be a part of action at WIROC Max 2022 and stay tuned to what's happening latest. So again, I thank you, all of you, for joining on this Saturday evening, on the pre-evening of the Christmas Day, and on the behalf of the Executive Committee of the Bombay Orthopaedic Society and the Organizing Committee of WIROC Max, I wish you a Merry Christmas in advance and hope to see you in person at the WIROC Max 2022, which is the annual conference of the Bombay Orthopaedic Society, which is scheduled from 29th to 31st December 2022 at the Geo World Convention Center, BKC, Mumbai. Also, we will be having a one virtual day program on 28th of December, which is Wednesday, where we have 150 surgeries on your platter. You will be receiving a link to join this platter and enjoy it. So hope to see you soon in person at the conference. Bye-bye, good night, and see you soon.